Chapter.
Yes, good morning again. Good morning again. Chapter 14, regulation of breathing. So in this chapter, what we're going to see, what we're going to study, it is about what is regulating our breathing. What part of our body regulates our breathing? That's what basically we're going to learn. Page 317, left column, 2, 4, 6, 8, line number 8, you want to highlight there where it says, towards the end of that line, the rhythmic cycle of breathing originates in the brainstem, mainly from the neurons located in the medulla. So when it says rhythmic, we need to know this, that is a rhythm and a pattern. When we are saying rhythmic, you will see as it goes through. It makes a rhythm. And what that means, we are going to so this part, we are inhaling, and this part, we are exhaling. Arrow down, we're talking about negative pressure. Negative pressure, we're talking about in the alveoli, or I'm going to say PALV, referring to alveolar pressure. It becomes negative during inspiration. We know that part. And then during exhalation, it becomes positive. Again, we're talking about alveolar pressure. So it's a cycle. It's rhythmic. It never stops. So we can have also a circle. The circle also talks about the fact that we are inhaling. During inhalation goes down with negative pressure, and during going up, which is exhalation in that case, pressure is positive. And we know when we're talking about positive pressure, negative pressure, we are referring to alveolar pressure. So it says the rhythmic cycle of breathing, the reason we breathe in and out, in and out, in and out, it says that originates in the brainstem. The very first part of our body starts to become when we are in the fetus or fetal development part, mainly from the neurons located in the medulla. So brainstem, medulla part, that's where it comes from. And the best way of looking at it is looking at the figure 14-1 in page 317. It tells us that what we're talking about as far as pons, which is on top part, medulla oblongata, which is the middle portion, and after the end, we are starting the spinal cord. And then 4 lines after you highlighted where you left off, towards the middle sentence, 4 lines down after comma, it says, precisely controlling ventilatory rate and depth to accommodate the gas exchange needs of the body. So this, what we talked about, when we are saying so we have pons on top, and then we have medulla, and then the rest of it would be the spine. So these sides, as we talked about, bilaterally located on medulla, these neurons are responsible for the rhythmic pattern of the breathing. Inhale and exhale, inhale and exhale. These are responsible. Okay, so when we're talking about medulla, that's what's going on. Controls the rate and depth. So controls the rate, which is respiratory rate. And then it says control something else also, depth. We're talking about tidal volume in that case. So if in case you are running, or if you're doing exercise, or if you're lifting, then the rate will go up. Medulla is responsible. When you're lifting, tidal volume will go up. Medulla is responsible because it sends a message to accommodate what body needs, so it increases. So, and you know that once we increase the respiratory rate and tidal volume, it means automatically we increase minute ventilation. The part of the minute ventilation is your concern is alveolar ventilation. Alveolar ventilation is something that you want, and that's the responsibility of increasing the minute ventilation because you want to do gas exchange, because body wants to do gas exchange. 317, right column, second line. At the beginning says the medulla, after comma, the medulla contains several widely dispersed respiratory-related neurons. Two main ones that we're going to know or learn is DRG, which is dorsal respiratory group. These are inspiratory neurons. So you want to do this way, that D or G are good for inspiration. They are causing the inspiration to take place, to kick in. And then it says, whereas the ventral respiratory group, or VRG, are both responsible for, so VRG are responsible for inspiratory and expiratory. Okay, so every time you inhale, two sets of neurons are going to fire. Because what we have, the diagram tells us, VRG responsible for inspiratory, VRG inspiratory and expiratory. Under the heading dorsal respiratory group, you want to highlight right after it says figure 14-1, comma, so you want to highlight DRG neurons, just these two words. And then you want to go to line number 4, and you want to highlight where it says providing the main inspiratory stimulus. So DRG are responsible, and if we read, it says, second line towards the end, it says this: these neurons, referring to DRG, send impulses to the motor nerves of the diaphragm and external intercostal muscle. You need external intercostal muscle to do the work, and that work is inspiration by expanding the thorax and lifting up the thorax, providing the main inspiratory stimulus. So that's the responsibility of DRG. How does DRG work? Sends a message. As a result, that's what's happening. Under ventral respiratory group, under heading ventral respiratory group on page 317, right column, you want to highlight the first sentence, which is 2 lines and a word. VRG neurons are located bilaterally in the medulla in 2 different nuclei and contain inspiratory and expiratory neurons. some inspiratory VRG neurons send motor impulses through the vagus nerve, which we talked about. That's cranial number. The vagus nerve is cranial nerve. You said.
Oh, that cranial nerve.
That's what you're referring to here now. So some inspiratory VRG neurons send motor impulses through the vagus nerve to the laryngeal and pharyngeal muscle. These are important. So when you're talking about laryngeal and pharyngeal, so let's take a step back and ask a question. If we have nasal right in the back, when we're going down, we're talking about nasopharynx. There are muscles in the back. Oropharynx, laryngopharynx or hypopharynx, then larynx. So these are all having their own muscles, and they're having two sets. There are pair muscles when we're looking at it. So these muscles are responsible, and look at what it says. Some VRG, some inspiratory VRG, they send impulses through the vagus nerve, cranial number 10, through them, to the larynx and pharynx muscles. Okay, what do? Abducting the vocal cords. Okay, abducting. So we just need to know the word abducting, right? So we want to look up, thank you. So that's what we're talking about. And increasing the diameter of the glottis. So as we said, during inspiration, we have a formula in physics that we said during inspiration, we increase the volume of, this is V refers to volume of thorax. That's what we're referring to. We increase the volume of the thorax. We need to know this, that when we are increasing the volume of the thorax, everything else will become engorged and enlarged, such as all the airway. So if we're looking at trachea, we're going to dilate our trachea also. All our airway will be, and the reason behind it, because you want to take air in as much as possible. As much as possible, you want to take air in. So you want to open up the structure. That's what they're talking about. So this is the VRG part of it. And then 318 on top, it says the exact origin of the basic rhythmic pattern of ventilation is unknown. Do we know it exactly? No. We're still studying this science, or this part of the science is not clearly known absolutely. There still has been some study done. But we're just going to look at it. What are we talking about? Like how things are happening. We're just guesstimating, and we're trying to figure things out because it's not easy. It's a nervous system, and we cannot cut down the nervous system of other humans and trying to figure out, oh, this is how we breathe. Well, it's not going to work out that way. We have to practice it on animals and then apply it to humans. So that's what they're referring to. But we're going to take a quick look at a couple of them. No single group of pacemaker cells has been identified. Two predominant theories of rhythm generation are the pacemaker hypothesis and the network hypothesis. So we have two of them in there. These two hypotheses are saying how we breathe. Which one is true? We don't say that. Well, we're just going to look at which one says what. Okay, so the pacemaker hypothesis holds a certain medullary cells that intrinsic pacemaker properties, example, rhythmic self-exciting characteristic, and that these cells drive other medullary neurons. So that's the pacemaker. Pacemaker, it works on its own, it has autonomy, it works, it kicks in. And then the network hypothesis suggests that arrhythmic breathing is a result of a particular pattern of interconnection between neurons dispersed throughout the rostral VRG and pre-Botzinger complex and the Botzinger complex. So we just want to be familiar with how many hypotheses we have. Number one, pacemaker, it just fires just like the myocardium, and it has the ability to go into do the action potential. So as this one, that's a pacemaker hypothesis. And the other one is network, which if you look at it, again, the terminology refers to what they're talking about, meaning that I activate you, you activate another one, and another one activate the fourth person, and keep going on and on and on. That's what basically they're talking. And then inspiratory REM signal, third line, it says, rather, the firing rate of DRG and VRG inspiratory neurons increases gradually at the end of expiratory phase, creating a ramp signal. The inspiratory muscles contract steadily and smoothly, gradually expanding the lungs. That's why our breathing, it is seamless. You don't see you do a lot of work. The work is done really smooth, and rather than being rhythmic and cyclic, meaning that it has a rhythm that you don't feel it unless you do the strenuous exercise, or if you do heavily workout, then you do see it. Otherwise, what you see is our breathing happens by really a smooth pattern of really nicely coming back and forth like a frequency of the wave as it goes through. And it's not turbulent. Like we don't breathe like if you look at the breathing of a dog, how they're doing, they're panting a lot of time. And especially if they do even 5 steps, but we don't. We go about, we do activity, we sit down in a classroom, we talk, we go through the lecture, we take a test. We don't even know we do breathe. We don't even know about heart rate either. We don't even know about the heartbeat. Same applies to our breathing, and that's the result of it. And if you look at the diagram, this diagram is actually a good representation of what it says in that few lines that you highlighted. So beside that, we're going to look at page 318 on the right column. We're going to look at Pontin Respiratory Center. Pontin refers to ponds and the respiratory centers that are located in ponds. So, at the bottom of that line, please, go ahead. Pontin Respiratory Centers, that paragraph, towards the end of a paragraph, it says 2 groups of neurons in the ponds. We're talking about they're responsible for the breathing, for the respiration. Number 1 is apneustic center, and number 2, the pneumotaxic center. Apneustic is anatomically ill-defined. Under that heading, you can read it, what it says. Its existence and function can be shown only if its connection to the higher pneumotaxic center and vagus nerves are severed. Meaning that due to accident, we have a lot of patients who come to the hospital and we see that they had some sort of accident to their nervous system in that area. At ponds, we conclude the result of a damage to that area causes breathing to go this type of a pattern, which we're going to call it apneustic pattern, and we're going to get to that part also. And look at what it says. It's black and bold in few lines down in that section. Under such circumstance, the DRG, dorsal respiratory group, inspiratory neurons fail to switch off. So meaning that this part, when we do inhalation, it has to switch to exhalation, and it doesn't. So we realize apneustic center is responsible for switching off the inspiratory part. Because what is happening here, when you start inhaling, and you keep going this part, and you keep going this part, your lungs become inflated. You fill up your lungs, and you go, and you go, and you go, and there should be a point that the switch turns off. It has to, because you have to be able to stop and then allow the lungs to get exhaled out or emptied out. This is the point that switch off should take place. This is the location. So what we realized, apneustic center or pons at this location is responsible for switching off at the end of inspiration. That's what this means. Causing prolonged inspiratory gasps interrupted by occasional expiration. As a result, we call it apneustic breathing. So apneustic breathing, the characteristic of apneustic breathing is prolonged inspiratory gasps interrupted by occasional expiration. Because what they do is, it is going to be something like this. They're taking a breath. So they gasp for more inspiration, but lungs are not able to take more in because they already being filled up. And then they have no choice but to decrease the structure, decrease the volume to let the air out. And then at the same time, they start going back to inspiratory and trying to take some inhalation. Vagal and pneumotaxic center impulses hold the apneustic center's stimulatory effect on the DRG neurons in check, meaning that apneustic center on its own is not going to be responsible for everything. We have another two neurons that are controlling, that are making sure apneustic center does the work properly. Those two are vagal and pneumotaxic center. All right, let's look at the pneumotaxic center heading. Pneumotaxic center is a bilateral group of neurons located in the upper pons. So if you go back and take a look at what has happened, pons are going to have a couple of sections as it has, and you can look at it. So the top part is pneumotaxic, the bottom part. So this right here. So we have this part. You have it in page 317, of course. But if you want to look at it here also, you can look at it as well. The blue and the black part. So the blue refers to pneumotaxic. This is the pneumotaxic center. And this black portion refers to apneustic. And you can also refer to and understand this part, that it says apneustic, so refers to some sort of a abnormal part of the breathing, and pneumotaxic, whether it puts it extra toll and taxes the respiratory center, or it doesn't do the job as far as controlling. So what we talked about apneustic center is, if it is severed, it causes prolonged inspiration with occasional expiration. That's what, gasping inspiration, yeah, prolonged inspiration with gasping, and occasional expiration. So pneumotaxic, that's where pneumotaxic are located. Bilaterally they're located. The pneumotaxic center controls the switch off point of the inspiratory ramp. Okay, at least we have something to work with. At least we can stop. Controlling inspiratory time. Oh, we heard of inspiratory time before. Inspiratory time, we're talking about this portion right here. This is the part. We talk about pressure goes negative. Also, we're talking about this, that this inspiratory has another component, which is time, I time, or inspiratory time. We always talk about inspiratory time. We always talk about how important inspiratory time or expiratory time is based on our patient care and what type of a patient we have. We modify our inspiratory time for our patient, or expiratory time we modify. We do something about those. And the strong pneumotaxic signal increases the respiratory rate. So pneumotaxic is responsible for respiratory rate. You can think of that like what? In you and I, we're talking about doing any workout. If we're going up the stairs about 2-3 stories, or we go about like 4 or 5 flights of the stairs, our respiratory rate will increase. Who's responsible is pneumotaxic. And weak signals prolong inspiration and increase tidal volume. Oh, so number one responsibility is to increase respiratory rate. Another thing that what it does, it lowers the respiratory rate, or I should say it lowers the I time, because it says prolong. And then as a result, increases the tidal volume. So what it does, it lowers the inspiratory time. And if you do lower the inspiratory time, it means you have more time to increase the tidal volume. And this is the center that is responsible for such activity. The exact nature of the interaction between a pneumotaxic and apneustic center is poorly understood. Again, we do not have a great deal of understanding yet about these centers. These are all from evidence that we have from some patients who come to the hospital due to injury. Now this is the part that we understand, okay, from this accident or from this problem that these patients have, we learn these ideas. They apparently work together to control the depth of inspiration. So these two together, they work. When we're talking about depth of, we're talking about tidal volume. Depth, we're talking about tidal volume. How deep you breathe or you don't, it means pneumotaxic and apneustic are working together to facilitate low tidal volume, low depth. We're talking about shallow breathing or shallow tidal volume. Or, on the other hand, deeper or larger tidal volume, we call those hyperapnea. Hypopnea for low tidal volume, hyperapnea for larger tidal volume. So we want to know our terminology as well. Bradypnea, tachypnea refers to the rate. Hypopnea, hyperapnea refers to depth or the number or the large or less being tidal volume. Reflex control of breathing on page 318, right column, the last heading. Under that heading, you have something called Hering-Breuer inflation reflex. This is actually really easy, but you just need to know that usually they ask this question, what is Hering-Breuer reflex? Well, it's the inflation reflex, but they're going to leave the inflation part out to see, do you know what this is a stand for or not? And this is what it refers to. This is where you want to highlight. You want to highlight the first sentence where it says is generated, these reflexes, the Hering-Breuer reflex. These two guys came up and found it. Generated by a stretch receptors located in the smooth muscle of both large and small airways. Again, we are going and we are dealing with the smooth muscle. That's why the smooth muscles are extremely important for us to understand, because when we do bronchodilator, adrenergic drugs, they are affecting the smooth muscle. When we do anticholinergic drugs, they are affecting the smooth muscles. So that's something you want to know and you want to study. So page 319, right on top, Hering-Breuer reflex, you want to highlight from this part. Regulating respiratory rate and depth during moderate to strenuous exercise. So when you exercise, your body wants to open up the thorax and inhale as much as possible. But there are receptors, there are check and balance involved, and those check and balance, what they're doing is they're controlling. What do? They control the rate and the depth. So you don't want to open up the structure to cause injury. So Hering-Breuer controls it. Deflation reflex. So the inflation reflex is first, and the opposite would be deflation, and we pretty much know. The last sentence of deflation reflex paragraph says, the deflation reflex is probably, you want to highlight this part, is probably responsible for the hyperapnea observed with pneumothorax, air in the pleural space. Pneumothorax, I'm sorry, pneumothorax, not pneumotax, pneumothorax. So deflation reflex is probably responsible for the hyperapnea observed with pneumothorax. Someone who has pneumothorax, you're going to see that they're going to go a really large tidal volume, compensate for the fact that their lungs been pushed by the air in the pleural sac, in the pleural space, which it shouldn't be there. Because if we have air in there, it pushes down on the lung. Now, deflation reflex, what it wants to do is, wants to go against it, have a larger tidal volume to compensate for such a defective issue, such a problem that we have. So that's what's coming to effect. Head paradoxical reflex heading. Second line, it says lung hyperinflation, so you want to highlight that part. Lung hyperinflation causes a further increase in inspiratory effort. That is correct. The opposite of the Hering-Breuer reflex. So lung hyperinflation causes a further increase in inspiratory effort. You have to even open it up farther. That's what it is. The receptors for this reflex are called rapidly adapting receptors because they stop firing promptly after a volume change occurs. Volume change, we talked about this part. Boyle's law explains. When the volume goes up, we inhale and the volume comes down. That's the change right there. Volume changes. This change of the volume is controlled. So all these mechanisms are in place because we want to control. We want to control during inspiratory. We want to control during expiratory. So let's go back and see what are we talking about. First, we talked about neurons that are responsible. That's what we talked about. Apneustic and pneumotaxic. They are responsible for our breathing. They're sending a message. You can look at them as commanding center. They are sending signal. They are sending the message. Okay, now message has to be received and processed and executed. Does that make sense? So the message has to be received. Who's going to receive the message? All these reflexes, they do receive the message and process. What do? When they receive the message, they are processing what they need to do next step. Do they need to decrease the frequency by lowering the respiratory rate and tidal volume? Or they need to increase by increasing the rate and increasing the tidal volume. If we have a lot of demand, we need to increase the minute ventilation. If we have production of a high amount of a CO2, we need to increase tidal volume. How are we going to do that? We're going to fire more, we're going to send a lot of signal, but someone out there needs to receive, process, and execute. These are the center when we're talking about reflexes of the control of a breathing. These are the guys that are responsible. Under irritant receptors, what you want to know, pretty much under irritant receptors, you want to know everything and everything and everything. The reason behind it, I'll tell you exactly what to focus on, but you want to study everything and know everything under that. Because irritant receptor, as the name comes, anything, there are receptors in our lungs that are responsible to sense anything that causes irritation to the respiratory center, to the respiratory system. So what you want to focus on is line number 4, the stimulation. Okay, so number 4 causes, this is where you want to start highlight, causes reflex, the bronchoconstriction, coughing, sneezing, tachypnea, and narrowing of the glottis. Some of these reflexes called vagal reflexes have both sensory and motor vagal components. So they do sense the irritation and they respond to it by motor activity. Motor means that they do something, they do the work. They are responsible for laryngospasm. What are you going to do for laryngospasm? As a respiratory care practitioner, what are you going to do for laryngospasm? Bronchodilator, thank you. Coughing. You're going to monitor your patient to make sure this patient has a proper coughing. They should have a good cough, because if they don't have a good cough, you know that you studied also in hyperinflation and bronchial hygiene, they're not going to be able to bring the secretion and phlegm up, and if they don't, then they're going to have accumulation, and they're going to have more and more problem, meaning that when our organism will grow, or they have mucus plugging, airway exchanges not taking place and all that. So, and a slowing of the heartbeat. So you want to watch out. What this means when you're suctioning a patient, there is a possibility that you hit the vaso or vagal reflex. As a result, heart rate goes down. You are responsible to watch out for such a heart rate and monitor this heart rate is okay or not, and make sure your patient is okay. Next sentence says endotracheal intubation. Airway suctioning, which you guys do all day. We all do it all the time. And bronchoscopy readily elicit vagal reflexes. It does. That's why we should be responsible and we should be very vigilant about when we're in ICU and we are suctioning our patient, always one of our eye has to be on the monitor to watch for the rhythm and heart rate. And as soon as the heart rate drops, we want to give the patient 100% oxygen. That's number 1. And number 2, we want to watch out. We want to make sure that this patient is okay and the heart rate go back to normal. J-receptor. J-receptor, what you want to do, J-receptor is actually really interesting. This is part that we understand why things are happening. J-receptor, J stands for juxtacapillary. Okay, so juxtacapillary, you want to find out what this is. There are fibers, we're talking about neurons. Of course, we have nervous system all over. We have neurons, we have nerves all over. So C fibers in the lung parenchyma near the pulmonary capillaries are called juxtacapillary receptors or J receptors. Alveolar inflammatory process, pneumonia. Pulmonary vascular congestion, CHF. pulmonary edema stimulate these receptors. And if you look at, we are talking about this wall between alveoli and capillary. This is the structure, another structure, and another structure. Each of these structures, if they are damaged for whatever reason, for example, if this is get congested, we call that pneumonia. Alveolar congestion, it says, we call that a pneumonia. And then we have something else, it's called, look at what it says, pulmonary vascular congestion. This is the part that refers to capillary. So this is your CHF. The reason or what's going on, we have congestion of a vascular. That means we have some sort of problem and capillary is not working well. And then we have another one, which is pulmonary edema. These two, this right here, CHF, because the vasculature has been taxed or has been heavily engorged, fluid will ooze into this part. It shouldn't, but it goes because high pressure causes the fluid to go to a least or less resistant path. So it goes into the alveoli. As a result, we have problem, we call that a pulmonary edema. In that case, who becomes to get stimulated is J-receptors. Okay, the stimulation causes rapid shallow breathing. Whether you have seen it in some patients or you will see it when you go back in your ICU rotation. During ICU rotation, you will get patients because look at the alveoli supposed to be or should be, alveoli should be having a really nice and thin. So we're going to talk about, this is our capillary. And of course, this is our alveolus. Should be really nice and thin. However, if we have fluid exuding from capillary into the alveoli, now this alveoli, instead of having air, now it has some plasma and some fluid. If you look at, now we're going back again, we're talking about distance. The distance normally should be here. This should be the distance. This should be the normal distance. However, under the case of a pulmonary edema, our distance becomes way larger, and that distance refers to this distance is not good. Because the reason it's not good, because we said for the driving pressure for O2 is 60 millimeters of mercury. 100 minus 40 gives us 60. That's the 60 we're referring to. 100 is in the alveoli, 40 is in the capillary. As a result, gas moves due to a larger distance in the case of a pulmonary edema. Now, this driving pressure of a 60 millimeters of mercury is not enough to push just because we have a farther distance. Our AC membrane should be lesser or thinner than the paper. But if we have fluid in there, now this driving pressure has to work against not only a structure we call AC membrane, but also has to work against the fluid as well. So it's not going to be good. As a result, our patients are going to have rapid breathing. They're not going to be able to have a larger tidal volume because their alveoli are flooded with fluid. So as a result, they have to compensate somehow, some way. They have to compensate. And think of it this way: we know that minute ventilation formula tells us respiratory rate times tidal volume. if tidal volume drops, if tidal volume decreases, in order to keep the minute ventilation constant, K for constant, if we want to keep it constant, then we have to do something with the respiratory rate. What do we do with the respiratory rate? We increase the respiratory rate. Then if you do increase the respiratory rate, you automatically, what you're doing is you're increasing work of breathing. That's something that you don't want to do. And our job as a practitioner all day long is for our patient to lower work of breathing. We want to lower the work of breathing, always, every day. Every day we go to work, our job is to decrease work of breathing for anyone and everyone. Just because increased work of breathing is not helpful, it's not physiologic. As a result, we are there to help, we are there to make sure it doesn't happen and it gets reversed. Correct. It sends a signal that we have been stretched more than what we should due to some sort of an insult to the structure, whether the insult has been to the alveoli itself, in the case of a pneumonia, has been flooded due to, first of all, infection can cause inflammation of the alveoli. And then number two, we talked about CHF, which has something to do with the capillary. So the capillary has something happen to it due to a pressure change, another problem we have. And later stage or after CHF took place, now we have pulmonary edema. There are possibilities that you and I go to the hospital, end up with the pulmonary edema, by the way. We don't have to have CHF. There are patients who come to the hospital for some odd reason. Sometimes we do make mistakes. And as a result, for example, if you come to the hospital and instead of giving you 1/4 or 1 liter fluid over the course of the 24 hours, if we give you 1 gallon by mistake, and if I don't report to you when you come on board and you don't know and we keep giving you fluid, this fluid has to go from a higher pressure to a lower pressure, from a higher pressure to a path of the least resistance. As a result, it exudes into the alveoli. And now we have a problem which was not a problem to begin with. So now we need to do something about it. For someone with the pulmonary edema, what are you going to do for that patient? Diuretics. Okay, diuretics is good. That's medication. What else are you going to do? You're going to do BiPAP. There you go. So one of the things that we want to know and we want to do for our patient in the case of the CHF, we want to have a BiPAP standby, ready, because there is a possibility that these guys are going to go into pulmonary edema. And if someone is pulmonary edema, what kind of a breath sound? Yeah, you're going to hear like a washing machine. Like people who can't describe you about their breath sounds, they tell you, oh, it's like a washing machine. And it is correct because you're going to hear a lot of fluid in there, which fluid should not be there. It should be air only. So as a result, what do you want to do? You want to get BiPAP, and what you do with BiPAP, this is the issue we have. This issue is getting reversed. Completely? Not really, until we do some other modalities, such as diuretic over the course of a time. And if there is a case of a CHF, whatever cardiac medication we need to give in order to have a better control of a CHF. So it's not, the pressure is not going so high that it's out of control. Page 319, left column, the last heading, peripheral proprioceptors. These are interesting, really interesting receptors. So you want to highlight the first 4 lines, which goes to the next column. Proprioceptors in muscles, tendons, joints, and pain receptors in muscles and the skin send the wow. Okay, I can't even talk right now. Let's have some water. Okay, send some stimulation signals to the medullary respiratory center. Oh, we didn't know that, but we knew something else. Such a stimuli increase medullary inspiratory activity and causes hyperapnea. You might have this experience, or you might have seen it in the movie. Someone who passes out Friday night, Saturday night due to a heavy-duty party, what do? You splash some cold water on their skin or face, right? And what happens to them? And they wake up like this. They wake up and look at that's hyperapnea, right? That hyperapnea is right there, explains what has happened. But what you're gonna know is muscle, tendons, joints, these are all responsible for you when you do exercise. Causes you to have larger tidal volume. These are the receptors. So we learned Hering-Breuer, it stops the increased inflation, it stops the inflation at some point. Deflation reflex causes further deflation, go back. Head paradoxical reflex is responsible for our yawning and hyperinflation, opens up to recruit alveoli. Irritant receptors are responsible for sensing irritation and protecting respiratory system. J-receptors are responsible when any insult has happened to the structure of the AC membrane to protect. Peripheral proprioceptors are responsible for any other method or any other senses that we need to increase the ventilation. Because ventilation goes hand to hand with cardiac, and our life depends on respiration and cardiac, cardiovascular as well. Page 320, we want to know everything about it right there as far as understanding chemical control of breathing. And when we're saying chemical control of breathing, we're talking about only a few chemicals. And those chemicals are O2, CO2, and hydrogen ion. That's what exactly we're referring to. And we are going back to medulla again. This is where you want to start highlighting. 320 left column where you see chemoreceptors in black bold. Go 2 lines down, right beneath. The sentences start this. Centrally located, so you want to highlight from this point. Centrally located chemoreceptors in the medulla respond to hydrogen ion. So central chemoreceptor, though these guys are central chemoreceptors, it's a centrally located, which normally arises from dissolved CO2 in the cerebrospinal fluid, or CSF. We're done. This is about central chemoreceptors. Peripheral chemoreceptors are located chemoreceptors in the fork of the common carotid arteries and the aortic arch, are also sensitive to hydrogen ion and indirectly to CO2. These receptors are also indirectly sensitive to hypoxemia, because hypoxemia increases the sensitivity of the peripheral chemoreceptors to hydrogen ion. So you want to highlight that part. Under central chemoreceptors, the first paragraph, which is long relatively, you want to highlight the last sentence. The last sentence says, alveolar ventilation increases by approximately 2 to 3 liters per minute for each 1 millimeter of mercury increase in PaCO2. So every time PaCO2 goes up by 1 millimeters of a mercury, our body adjusts itself to increase the alveolar ventilation. Please do not make a mistake by minute ventilation. This is alveolar ventilation. And alveolar ventilation, like I put it up there, alveolar ventilation, when we're talking about minute ventilation has a component of it. Alveolar ventilation plus dead space ventilation. That's what makes the minute ventilation also. So the factor that we are responsible, we want to know, is this one, which is alveolar ventilation, because alveolar ventilation does the gas exchange. Dead space ventilation, if you increase or decrease, if you increase, you increase the work of breathing. If you decrease work of breathing. And continues to the next paragraph, you want to highlight the stimulatory effect of a chronically high CO2 on the central chemoreceptors gradually declines over 1 to 2 days because the kidneys retain bicarbonate ions in response to respiratory acidosis, bringing the blood pH level back towards normal. You guys already know it because you guys have studied ABG. You know how the arterial blood works, and you know when the lungs are not working, kidneys are working. So that's where it refers to. That's where it goes to. And this is about central chemoreceptors. So central chemoreceptor does a lot of work. You want to study some other parts, and pretty much what we covered is talking about, again, central chemoreceptors, peripheral chemoreceptors. So we have 2 sets, central chemoreceptors and peripheral. Both of them are located for check and balance, and they do their work. Peripheral chemoreceptors, you want to highlight the first sentence. They're small, highly vascular structure known as the carotid and aortic bodies. Right there, they are sensing O2, CO2, hydrogen ion. That's what they're responsible for. And then you want to highlight page 320, right column. The heading says, response to decreased arterial oxygen. This paragraph, you want to highlight everything about it, and the entire paragraph is something that you want to know. Traditionally, it was believed that the carotid bodies directly sense low PaO2, implying that arterial hypoxemia responds an independent drive to breathe, the hypoxic drive, which you guys are familiar and we study a lot and we talk about it. Although the peripheral chemoreceptors fire more frequently in the presence of arterial hypoxemia, they do so only because hypoxemia makes them more sensitive to hydrogen ion. It's because they're more sensitive to hydrogen ion at this time that they fire more. So you're going to study the rest of it, see what it says, when it's low, when it's high, and how it works. Since we are there, make sure to highlight rule of thumb, page 321, right column, very top, rule of thumb, you want to highlight. And under the heading, following under the heading, response to increased PaCO2 and hydrogen ion, you want to highlight the second sentence that it starts this way. The peripheral chemoreceptors account for only 20 to 30% of ventilatory response to hypercapnia. And then you want to go down 3 lines after you're done. On the 3rd line, highlight this part, comma, towards the end. The carotid bodies are exposed directly to arterial blood. go to the next paragraph, as stated earlier, hypoxemia, that's where you want to start highlight. Hypoxemia increases the sensitivity of the peripheral chemoreceptors to hydrogen ion and to PaCO2. So you want to highlight, keep going to the next sentence also. The sentence ends with almost zero. And then you want to go to the next paragraph where it says number 1 and number 2. You want to highlight number 1 and number 2. Again, still we're talking about hypoxemia and hypoxia and how the body refers to, how to work with it and all that. So in that paragraph, you want to highlight what it says. Number 1, high PO2 renders the peripheral chemoreceptors almost unresponsive to PCO2. And number 2, low PaCO2 renders the peripheral chemoreceptors almost unresponsive to hypoxemia. It's pretty twisted about the situation. Each of them, if it is too high or too low, affects the other one to be insensitive. That's why these systems are not clashing with one another, rather they're responding to one another. They're following one another. Page 321, under the heading Control of Breathing and Chronic Hypercapnia, you want to highlight the first sentence. A sudden increase. So that's the sentence you want to start highlighting. Page 322 is something really nice and really good about mini-clinic, talking about high altitude. Those of you who are going to prove, it would be good if you're going to Big Bear or any elevation or high elevation. You probably want to take a look at it. It's fun to read. You will get some sort of a question maybe about this. So, try to have a little understanding about what it says here. Right column, page 322, right column under oxygen-associated hypercapnia. You want to highlight the 1, 2, 3, 4, 5, 6. Yeah, you want to highlight first 7 lines. And you want to go to the end of this paragraph and you want to highlight the last 6 lines. So count from bottom, go up. It says O2 breathing, you want to highlight. O2 breathing worsens the VQ ratio relationship in the lungs and is responsible for the increase in PaCO2. Other investigators have suggested that O2-induced hypercapnia is caused by the combined effect of the hypoxic stimulus removal and redistribution of the VQ relationship in the lungs. So breathing O2 is good, but not always good. Is good, but not good. That's what we were talking about. That's what we're suggesting. Again, under O2 therapy, you guys know about the vicious cycle, and you know about the O2 toxicity. Too much of the O2 is not good either. So this one goes back and talks about what can cause hypercapnia, sometimes O2 associated hypercapnia. So the next paragraph, you're going to let it go. And last paragraph, right column, page 322, O2 breathing, you're going to highlight 4.5 lines. And it ends with this, which causes blood PCO2 to increase further. Page 322, number 1 and number 2 is something that you want to study. It explains it. About 5 lines down into that explanation, figure 14-5. Page 323, figure 14-5 explanation of that figure, line number 5, it has number 1, lower the poorly ventilated units of the VQ ratio, and number 2, divert blood flow away from and ventilation toward already well-ventilated units. The latter increases alveolar data space, IVQ. You want to look at this. You want to be comfortable with this. And be sure when you're looking at this figure, the left 2 alveoli that you're looking at, FiO2 is 21%, so please highlight it. And figure B, the right 2 alveoli are FiO2 over 50%. So you want to highlight that also when you're studying it. You're not confused about what does it say? How come both of them look the same, but what are they referring to? And in order to be comfortable with this figure, you need to study it and then go back and re-study it and make sure you understand every sentence of it. And you're comfortable. So when you're tired, you want to let it go. You want to go take a break, which we're going to do pretty soon. Because we have almost nothing left. Page 323, left column, right above the heading central chemoreceptor. Count 4 lines. I want you to highlight this where it says tissue oxygenation is an overriding priority. You want to highlight that. You want to know this. Is because a lot of us, when we study what happened to us, we get hung up on the fact that, oh my God, patient has COPD, I shouldn't give O2. I shouldn't give O2 toxicity. Correct that O2 toxicity is something we want to be concerned, but our main concern is tissue oxygenation, always and always. We will deal with hypoxic drive in that case later on because we have a situation which is more important to deal with. Okay, so under central chemoreceptor heading, you want to highlight the first sentence, which goes about 3.5 lines. And page 323, right above rule of thumb, you want to highlight the last 2 sentences, about 5 lines. It starts, the central chemoreceptors of a chronically hypercapnic patient experience less stimulation than the central chemoreceptor of a normal individual for the same increase of a PaCO2. That's what we're talking about. That's why hypoxic drive is their last resort. And then you want to highlight the rule of thumb. Ventilatory response, page 324. Ventilatory response, you want to highlight the first 2 sentences, goes to 3 lines and 2 words. It ends with arterial pH constant. And the next paragraph, it says number 1 and number 2. You want to highlight those. You want to highlight those. And under abnormal breathing pattern heading, where it says Cheyne-Stokes, you want to highlight that part. It says respiratory rate and tidal volume gradually increase and then gradually decrease to complete apnea. So what we are saying is, so far we've studied different respiration pattern. Kussmaul respiration, apneustic, pneumothaxic, and this is one of the last one, Cheyne-Stokes. Not pneumothaxic, I'm sorry. Apneustic we did, Cheyne-Stokes we did, Kussmaul we did, and the next one is going to be Biot respiration. Under the Biot, you want to highlight page 324, right column. Biot respiration in black and bold is similar to Cheyne-Stokes, except the tidal volume are of identical. With Cheyne-Stokes, we were gradually going up, and then we were gradually coming down. With Biot, all the patterns are the same. So when we are talking about Cheyne-Stokes, we said this would be our tidal volume. So gradually come in, this is the apnea. So gradually it increases and then gradually decreases, and this is the absence of the breathing. With the biot, it's not. With the biot, what we have is they're all the same. And then it gets to this point, and then we have our apnea. So they're all identical. So the first one, this is the Cheyne-Stokes, I put CS, and then the second one, B for biot. Under carbon dioxide and cerebral blood flow heading, you want to highlight the first paragraph. Well, let me tell you exactly where. Third line, increase PCO2. You want to highlight to the end of the sentence, which is increase PCO2 dilates cerebral vessel, increasing cerebral blood flow, whereas decrease PCO2 constrict the cerebral vessels and reduce the cerebral blood flow. And then we want to go down last sentence of this paragraph. It says that is high ICP, intracranial pressure, may exceed cerebral arterial pressure and stop blood flow to the brain. So you want to highlight that as well. And lastly, but not least, you want to study the heck out of Mini-Clini in page 325, because this is something that you will be dealing with, you will be facing with. You will deal with it a lot and a lot and a lot. So you want to study that and you want to know it really, really, really well. First, try with any Mini-Clini, what you want to do is you want to look at it and you want to read it and see what you can do with the problem. You have the problem in hand. You want to look at it and you want to see what you can do. So what I ask you to do today is this, that all you want to do, all I gave you as far as highlighted are the part that, they're important, they're the essence. So instead of reading everything, my suggestion to you is you're going to go through the key terms like any other time. You want to go through the key terms and be comfortable. For example, page 316, key term, apnea. If you don't know what apnea is, my suggestion is first get to know what is apnea before you start this chapter. This is better. This is a better way of studying. And then you will learn about apneustic breathing as you go through. Apneustic center, you will learn. Biot respiration, you will learn. Blood-brain barrier, you probably want to take a look at it before you start. Or even if you go through, you will get to know it. Chemoreceptors, you should be able to break it down in such a way that if it says chemoreceptors, meaning that there are receptors, there are centers in our body that they sense chemical changes. So if you see baroreceptors, receptors that are sensitive to changes of a pressure. Chemoreceptors, changes of a chemical. What chemical? You should put down chemicals such as O2, CO2, hydrogen ion. So these are this is how you're going to study. And then get down to the key term. Key term is done. You want to look at what you highlighted first. Rush through. It's a pretty easy chapter. There's nothing fancy about it. It's only a few pages to study and to read. But it's important. But it has important message and important measure. Do you have any question for me? No question? You do?
Didn't you talk about the muscle spindles?
Muscle spindles, the reason about muscle spindles we didn't go is farther into, I can tell you where to were to highlight, if you like, 319, third line, muscle spindle, you can highlight right there. That's a good question. Sylvia is not letting it, is not leaving me without the little break. She's like, oh, no way, you have to talk about this before you can go. Yes, you're right. No, you're right, but I don't want you to get tangled up and confused about this because there are more important ideas in the chapter than that particular one. However, you can go ahead and highlight the third line that says muscle spindles are sensing elements located on intrafusal muscle fibers arranged parallel to the main extrafusal muscle fibers. What I do, my focus for you guys is to understand the concept, but not in such a depth that you will be overwhelmed / confused, because that will lead into you get exhausted, you get disappointed, and it's so much to digest because you don't have a lot of time. So my point is you get the essence, you understand the concept, the rest you can sit with it, let it sink, and it'll be fine. So that's the whole message behind it. So we're trying to, that's the reason I didn't talk about muscle spindle, because muscle spindle is something that's going to get into nitty gritty. We're going to talk about a little more involved. Will you deal with it? No, really. Are you going to get questioned on board exam? They're not going to ask you a question about muscle spindle. But they will ask you a question about Hering-Breuer reflex. So that's something you want to know. They will ask you a question about biorespiration. They will ask you about questions such as head injury. What are you going to do with that? They will ask you. They will ask you, ICP, intracranial pressure is high. What are you going to do for your patients? This patient came to the hospital with such and such injury. What are you going to do? Once you understand the mechanism behind it, the rest is easy. So that's why I didn't talk about those. But you're right. I mean, anything extra, I don't mind to talk about and go through it. But I'd rather put your focus first on CO2 before I go to talk about a whole bunch of other chemical reaction about CO2. Yes.
For page 320, central chemoreceptors.
Yes. Yes.
Thank you.
Sure, no problem. Yes.
The page 320, alveolar ventilation increasing by approximately 2 to 3 liters a minute for each milligram of CO2. I feel like that would, if you have like a hypercapnic patient, you already have low tidal volume. So can you elaborate more on that?
Correct. Go to page 323. And it says, right above the rule of thumb, you highlighted already. It says, the central chemoreceptors of a chronically hypercapnic patient experience less stimulation. That's where we're at. So what we're saying is this, right now, if your PaCO2 go up 1 millimeters of mercury, you're going to increase your alveolar ventilation 2 to 3 liters more. However, if you're hypercapnic, you already reach at high level and your body is not as sensitive as someone with the normal respiratory center. That's why we call the central chemoreceptors to be blunted. It doesn't mean that it doesn't work at all. It means that work less and less and less. Sometimes in the severe case of the COPD, then yes, probably the least it works. But it's less sensitive compared to you and I. That's how we compare the two. What else?
Didn't check that again, the reflection.
You had it because you highlighted.
It's a photo. Oh wait, I underlined it last night. But
There you go.
but I already
You
forgot.
did it. Yeah? All right, all right. Sounds good. Sounds like we're making progress.